Rotator cuff tears can occur as a result of injury, but most are the result of age-related degeneration. The shoulder is made up of three bones: the shoulder blade or scapula, the arm bone or humerus, and the collarbone or clavicle. The rotator cuff helps connect the humerus to the scapula. The rotator cuff is formed by the tendons of four muscles: the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. Tendons attach muscles to bones, and muscles move the bones by pulling on the tendons. A major role of the rotator cuff is to hold the humerus snugly in the socket or glenoid. It also helps raise and rotate the arm. The upper part of the scapula that forms the roof of the shoulder is called the acromion. A bursa is located between the acromion and the rotator cuff tendons. A bursa is a lubricated sac of tissue that allows for frictionless motion between two moving parts. In this case, the bursa protects the rotator cuff as it rubs against the acromion. Rotator cuff tears usually occur in areas of the tendon that normally have a low blood supply. The areas of poor blood supply in the rotator cuff make these tendons especially vulnerable to degeneration from aging. The degeneration of aging may be accelerated by repetitive shoulder motions, such as doing routine chores like cleaning windows, washing and waxing cars, or painting. Using excessive force can tear weak rotator cuff tendons. This force can come from trying to lift a very heavy object or from a fall directly onto the shoulder. The typical patient with a rotator cuff tear is in late middle age and has had problems with the shoulder for some time. This patient then lifts a load or suffers an injury that tears the tendon. Overuse or injury at any age can cause rotator cuff tears. Rotator cuff tears cause pain and weakness in the affected shoulder. A partially torn cuff may be painful, but there is usually no loss of shoulder motion. In general, the larger the tear, the more weakness it causes. A complete tear prevents a full range of motion and usually makes it impossible to actively raise the arm away from the side. A catching sensation is often noted when moving the shoulder. Pain when lying on the affected shoulder affects sleep. The diagnosis is begun with a careful history and physical examination. A complete tear is usually very obvious. The doctor is able to move the shoulder through a normal range of motion while the patient is unable to do so. X-rays won't show tears in the rotator cuff, but may show bony lesions that are associated with rotator cuff tears, such as bone spurs, loss of joint space, or a hooked acromion. An arthrogram may be done. This involves injecting dye into the shoulder joint. Dye leaking out of the shoulder joint is good evidence for a tear. Finally, magnetic resonance imaging, or MRI, may be used, as it does show tendons as well as bones. Non-surgical treatment includes the use of non-steroidal anti-inflammatory drugs, formal rehabilitation for strengthening and stretching exercises, and avoiding overhead activities. Corticosteroid injections may be used judiciously, as overuse ultimately weakens the tendons and may enlarge the tear. Generally, patients with significant symptoms and failed rehabilitation for 3 to 6 months should be considered for surgery. The exception is the younger patient who has an acute traumatic tear. The surgery is best performed within 6 weeks of injury. Many tears are amenable to arthroscopic repair, while some require the traditional open procedure.